If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Welcome, everyone, to Health Further. Marcus is traveling, celebrating his 10-year wedding anniversary. And so we're happy for him. And we have a great guest host today, Paul Kappelman, a friend of mine, expert in healthcare, is going to fill Marcus's big shoes.
Big shoes, for sure. So
welcome.
I'll do my best.
Yeah, thanks for doing this. Appreciate it, man.
My pleasure. It's always fun to talk healthcare with you.
So, Paul, I'm going to give a little bit of your background, but then I want to sort of talk through your experiences before we jump into it. We'll do the normal kind of review of all the news. It'll be good to get your perspective on things. It'll be different than what Marcus and I usually share. But you've been an operator in healthcare for a long time in the hospital world. A couple different. Well, you were in nonprofits and then in for-profit at Ardent, and then you did a private equity-backed fertility service called Ovation, right, that you built up and had a really good exit. Maybe 18 months ago? When was that?
Just about a year ago.
Yeah.
May of last year.
Yeah. And then you've taken some time with family and things over the last little while. But talk to me about your experience. What was it like operating inside big health systems and then running your own fertility?
Right. So, almost 30 years in health system operations. Hard to believe. I actually started working in hospitals when I was 20 years old. Wow. So, kind of found it in college and never looked back. Originally in hospitals and health systems. So I worked for a company called Well, it all starts with HCA, right? So I actually did work for HCA in Louisiana when I was 22 years old, and then worked for a spinoff company called Triad. It was a spinoff of HCA when they sort of broke up into LifePoint.
Right.
Triad was one of the spinoffs. I was out in Arizona, just grew the system. It was a really good time to be in Arizona. Population boom. Healthcare was underserved. And so we grew and grew and grew. Eventually, I convinced him to give me $100 million and build a brand new hospital. So I was employee number one.
And you saw it like from the ground up.
From the ground up. I was in a trailer and hired employee number two. And then ultimately 400 employees, and the hospital did really well. Yeah. And I was there for 3.5 years, and then Community Health Systems bought Triad. So that was my exposure and beginning to come to Nashville. By the way. Right. So I always knew I loved it and we're
glad you came here. Yeah. You didn't stay there. Yeah.
All roads lead to Nashville eventually. It just took me a little longer.
Right. Yeah. So talk about what that's like building a health system culture, like from scratch.
Well, I know you guys have talked a lot about culture and health systems and challenging. When you're employee number one and the CEO, if the culture isn't the way you want it, you have nobody to blame but the man in the mirror. So I knew that, and I was ambitious and maybe a little naive and went all in on culture, people first, and service and quality. And it worked, by the way. It worked. So because it worked, it was sort of a blueprint for me for the rest of my career. And whether I was at Ardent or Ovation, the fertility company, or at LHP, which is the company I went to after Arizona, really, I believed in if you do things right, you engage employees, make it a great place to work, make it as great of an environment for doctors as possible, focus on patient outcomes and quality, the finances usually take care of themselves.
Yeah. So you really spent a lot of time in the intersection of operations, finance, and culture. Is that fair in health systems?
Right. Yeah. People talk about, culture and strategy. And to me, you got to do both. Yeah. You got to do both. So culture trumps strategy is the saying, but I'm not sure about that. I think you can do both and be a disciplined operator, not just financial operator, but discipline on your quality and all of your metrics, all the pillars. Yeah.
And so give us the Cliff Notes summary of Ovation, because it was a really big, success. When you joined, what was the size? How'd you build it? And then we'll not the details of the outcome, but the outcome.
It was if you would ask me what I want to do after I was the chief operating officer at Ardent. I got here because Ardent bought our company in Dallas that I was running. And I would have never said fertility, but the opportunity got presented, and I was fascinated by the science of it, how quickly it was moving, And then the company had great alignment as physicians were partners, and they were truly engaged in the business, had an incredible private equity partner and Morgan Stanley Capital Partners that were very aligned. And when doctors are aligned, the management team's aligned, the board, the private equity sponsor, everybody's moving in the same direction, you can have outsized outcomes. So, yeah, we grew the size of the company organically, added a bunch of ancillary services that allowed us to grow, got the development function really going, and then did some things on revenue cycle, managed care contracting, and on the expense side. And we had outside results and had an unsolicited offer from U.S. Fertility.
Yeah.
And ended up getting a deal done in a pretty tough environment.
Right.
Yeah, at a good price and at a good time. So it was a good exit for everybody.
Yeah, excellent. And then you took some time off and, for not great reasons, got to see the other side of healthcare, right. Sort of the personal, your wife got really bad cancer and passed away. It was a really hard experience. But talk about the process of being an operator and helping doctors and patients through the care journey, but then being on the other side as not the patient, but the caregiver supporting the patient in a really hard situation.
Yeah. First of all, to think about, the people who are out there who are dealing with their own health issues or loved ones' health issues, and they're managing their own personal lives and the stress related to that, and have a job to do, regardless of what it is, it's just a lot. It's a lot. So I was fortunate that, the end, I was able to take off time, and I'm not sure how I would have done it without that. So I was very fortunate that we did have the exit. My wife had breast cancer. It was a very rare form of breast cancer.
The version of it or the type of it was really
very
bad.
rare.
Yeah.
Vanderbilt said since her passing, they've had one case.
Wow.
And they come to tumor board. So it was very aggressive, did not respond very well to chemo. We were treated at Vanderbilt, Dr. Park and his team. And I think that we're probably tough critics. I mean, I'm a former hospital administrator, so not the easiest person when I make sure people wash their hands in the room. I'm not afraid to challenge them on just about everything. And my wife was
every husband is concerned, but you know exactly what to look for and what to ask, and you can be critical, but in the right way.
Yeah. And but they were amazing, Vic. I mean, I came in a little bit of a critic and a cynic of Vanderbilt, just because they were going through their epic conversion and there was a lot of chaos. But I have to tell you that the team there was unbelievable. The communication, having everybody on the same electronic medical system, the team approach to the cancer care, hundreds and hundreds of appointments, maybe close to 1,000. The amount of time we were late was like 1%.
Yeah.
And they were just so compassionate and so communicative and responsive. I can't say enough great things. And we were fortunate enough, we live just south of town and we have the cancer center right in our neighborhood in Belmead. And that place it's unbelievable. It's a gem. Yeah. So I really...
In a bad situation, Dr. Park and his team did a good best they could.
And I think it's important to recognize that because it is sometimes we talk about what's wrong and we're going to talk about what's wrong. And I'm the first to talk about what's wrong. But that team of cancer care professionals are what's right in healthcare.
Yeah. And I think maybe not 100%, but a large percentage, 90, 95% of the people, maybe more, are really good people doing the best they can. Certainly systems and incentives and the structures are challenging. We'll talk about the news this week. Every week there's news about challenging artifacts of the way the American system's set up, maybe are less than ideal. But mostly the people are really passionate and work a ton of hours and are trying to deliver care. It's a calling. They get paid for it, but it's also just their life's work.
Especially the oncology team.
Yeah.
I mean, that's tough. We are going to do a little bit of a remembrance this summer. And since the Belmead Cancer Center has opened, they've lost 35 patients.
Wow.
And so I think about the toll that takes on those nurses.
Yeah.
And part of the reason that I plan on attending, and it's not going to be easy, is because I want to make sure they know how much their personal connections mean. And it'd be easy to stop doing that, getting those personal connections when you know you might lose somebody. But how important it is to the patients and their family members it's unbelievable.
Yeah, I mean, you could imagine a nurse getting a little calloused and like, I don't want to get that close because a significant portion of these patients won't survive. And that would really diminish the empathy and the caregiving that they can give. And I haven't found that many nurses do that, but then it's such a emotional toll on them too, that people don't really recognize as much. I think the nurses, especially nurses, but nurses and doctors and all the caregivers are.
I agree. And I found that because it's such a calling, that just that little great outcome or great story or that thank you from a patient or loved one, that may last them 5 years.
Yeah.
That one thank you note.
They think about, or they look back at, or that's hanging on their wall or whatever, at a hard moment. Yeah.
Yeah. So, I mean, you just can't say thank you. So part of my message to be to them is don't stop connecting the way you connected with us, because I'll be forever grateful.
Yeah. So, well, thanks for doing this. We're going to dive into the news.
Yeah, exciting.
I think it'll be fun. So, okay, so we're going to start on the economy. So this week on Wednesday, the CPI report came out. And for those listening, we have on the screen the inflation back to the 60s. This month, which is for April, it was 3.4 is the headline. And then if you pull out food and energy, 3.6. That was slightly better than expected. And, of course, it's still higher than the 2 that is the Fed's target. But it seems, reasonably stable now. And so it has come from people that are just listening. It's come down from, a year ago when it was up in the 7-8. It seems fairly stable at that 3 to 3.5 range. So do you watch the CPI? How do you think about the overall economy?
It's consistent. This is good news. It feels consistent with what you hear when you're talking to both professionals and colleagues and friends about what's going on. I still think people are feeling it every day at the pump. But this is solid, and you just hope that we, continues through the summer, so we could potentially see a cut this fall, maybe.
Yeah. I think this is what a soft landing probably looks like, right? So I don't know if we necessarily will hit it, but it seems like it's come down dramatically and the economy hasn't fallen out of bed. It's not really growing quickly, but we're not in recession.
And the market responded positively to the news. It's a month and we had some shaky in the first quarter, but this is good.
Yeah, that's right. I think we're all sort of getting to be aware that we're probably going to have inflation in the 2 to 3.5 for a while.
It's a little bit of the new norm.
Right. Okay. And then Bank of America put out a report. They call it Consumer Checkpoint. They basically take all of their credit card data and then they try to do analysis on it. And I thought 2 of the exhibits were pretty interesting. So we'll link to the entire report. But exhibit 1 and 2, we're talking about credit card spending across all categories. And it increased pretty significantly over the last month, which, I think is a good sign. People are spending. The consumer is a big part of the economy. This is sort of indexed against last year's average. So the 100 would be sort of like same as last year. We're doing better. Services are really growing quickly, which is actually good because that's a big part of the U.S. economy. And then interestingly, exhibit 2, the lower income seem to be spending more. Now that may be that they're using the credit cards more, but it seems like they're holding on or
which you would think could be counterintuitive given interest rates on credit cards, right? And we're going to talk about that.
The next story. So the next story leads to the next one, which is the New York Times had a story about high interest rates are really hurting the lower thresholds of the consumer, the lower income levels, which, I think it's a good thing to talk about. This story is fairly obvious. Like if you have credit card debt and you don't have a lot of assets that benefit from the stock market growing quickly, you don't own a house, you are suffering. There's inflation and high interest rates. So we keep watching this like K-shaped economy. I think it's a big.
You're not getting the benefits of the market increasing and you're getting penalized because you have credit card debt and higher interest rates. And it's a tough hole to work out of. Question I have is whether an interest rate reduction is really going to make a difference to somebody who's maxed out on their credit card debt. Is 100, 200 basis points going to make the difference, but it certainly doesn't hurt.
Yeah, I don't know that a couple rate cuts from the Fed are going to really matter. It's going to probably immediately pump up financial assets. but we need to try to get the economy going so that it kind of goes down to everyone. And I think that sort of leads into the next story, which is all the meme stocks are back. I think this is kind of a reaction to people that feel like they're missing out on the American dream and decide they're going to just try to basically gamble. And
that was exactly my thought. Why don't you just get on DraftKings and pick the Knicks? And I don't, but yeah, maybe that's the reason why they're. Well,
so popular. I think Roaring Kitty, which is the lead meme pumper. It's a Twitter X handle basically. I think his basic philosophy is it's better odds in the public stock market than it is in DraftKings.
If we gain momentum and get everybody talking about it, it will pump up.
If the crowd all binds together, and so here's GameStop. For those of you listening, it's the last 3 months of GameStop, and it's like, flat at $10, and then Roaring Kitty decided he came out in early May, started to buy some, and then went public this week, and it went up to $50, almost $50.
When was their real run? How many was that? 2 years ago, or was it?
Yeah, like in the pandemic.
In the pandemic, yeah, okay.
So I just took this image. I don't have it live, but like 2 years ago, it went up to about 80, and then back down again. So I don't think anyone, including Roaring Kitty, thinks GameStop is a good business. They're literally just like pumping it as a casino. But it's interesting because the short sellers got really burned last time. So I don't know. Anyway, I think that is like the general issue, that people that don't have huge amount of assets, that they'll maybe buy a crypto thing, or they'll buy GameStop, or AMC is a meme stock.
AMC,
I don't think it's good for the world, but I think it's here to stay. Okay, and then shifting to the venture markets, Carta, which is the biggest custodian for venture assets, like not traded, illiquid assets. They custody maybe 70% of all the venture firms and private equity firms. They aggregate all of their findings into a quarterly report. And so we'll link the whole report, but I pulled out, again, a couple of slides here. This is the total rounds and then also cash raised in the venture community over the past several years, back to 2018. And it's just really amazing to see the huge spike in 21, really peaking the end of 21, early 22. And now we're back down. I think really this just kind of the steady state that we're in. Something like 1,000 deals a quarter seems like roughly where we are, 1,000 to 1,500.
I would have thought the Q1 would have been a little more active. And I certainly hope that number goes up in Q2. You'd think it would, but it's surprisingly flat these last three quarters.
Yeah, I think we're not, I don't see us coming back to the 21, 22. I'd like to see it get to 1,500 a quarter. Would be, I think, great. We could see that. So then we have the valuations by round. So, the seed round, A, B, C, these, as the companies get more mature, you go through these stages. It's pretty telling. We're sort of flattened out a little bit, but compared to the peak, every round is down except for the seed round.
It's consistent. I don't know about what you're seeing, but I work with private equity companies and looking at deals. And the past quarter, we've looked at a lot of stuff with different people, and either have passed or it's been incredibly frothy and don't make it to the second round.
Yeah.
I mean, so it's kind of like one or the other. Either the company just needs to have an exit and they're really not worth what they're even thinking they're worth and don't end up doing a deal, or the deal is just overly subscribed and don't make it past the next. So this is consistent.
Does that mean like a sort of a flight to quality, like teams that are very experienced, or maybe you see the growth and the financials really trending well?
Yes.
Because the Series D is not private equity, but it's closer to private equity,
close.
maybe.
That's the 150, 100, 200 million. What was the kind of the Series D?
It's they don't have actual dollar amounts, but it's that kind of maybe you raise 50 to 100 million. Okay. You've been going for 4, 5, 6 years. but not at private equity where they're significant cash flow positive yet, still growing.
I think there's two things, right? One is the quality of the company, and two is sort of the valuations as they were doing add-on deals, right? So that's a lot of times in sort of the PPM roll-up kind of stuff. Some of the stuff that we're looking at is they're buying stuff at really high multiples, and so at higher than what a sort of roll-up company would sell for, they're buying individual assets. So then they may have a quality management team, have a good strategy, good alignment, but just can't get right on the valuation.
Well, and if your comps in the public market are lower than your buying acquisitions at, that trend doesn't work. I mean, eventually it has to all reconcile to whatever the public comps are, because that's you're either going to go public or you're going to sell to a publicly backed company. I think. I mean, there aren't many other options.
It'll be interesting to see what happens in the second and third quarter as companies. It's one thing to sort of hear it, and yes, valuations are lower. It'll be interesting to see what gets done at what valuations in the next 2 quarters. I think it'll really signify what's going to happen in the next couple of years.
Yeah. I think it's starting. I think it's healthy. I mean, I'm in more in the seed and A rounds, and deals are getting done there. It's not frothy by any means, but there are transactions happening and for reasonable valuation. Okay, so we're going to shift now to some individual deals. And so Glenn Tolman has I don't think it's that new, but he just raised his Series D, $126 million for Transcarent, I think is how you say it. He did Livongo and had a lot of success with that. He's using, he is good at understanding the zeitgeist. So he's doing an AI chatbot to bring transparency to healthcare consumers. He's raised a ton of money at a $2.2 billion valuation. So what are your thoughts about a consumer focused tool to bring almost like patient navigation and transparency to the patient population?
And there's a telehealth component. I had not heard of this company until you shared the article. The teledoc piece and the telehealth sort of, it makes sense that the valuation's gone down. It's a commodity now. Right? I mean, it's not that hard to do, and all these EMRs are having it built into their electronic medical record. The patient navigation, don't disagree with him on the problem at all.
Yeah. How you monetize? I mean, I don't know. He's doing. Glenn Tolman's made a lot. He's made more money than I've made. Yeah. So like he's smart, and he has raised a lot of money. He's in a Series D, and it's not clear to me what the business model is, which is, different.
Yeah, the patient navigation piece is something that it continues to be a problem, not through the whole health system and not just the insurance piece, but it is absolutely incredibly confusing. And I'm not sure if this is geared towards more of the front end on insurance or, hey, I have insurance, how do I navigate it? Both are problems.
I mean, I'm navigating right now, and both of us, we understand how to communicate with payers and providers. My son had a surgery. I mean, it was an elective thing, but you have to pay your copay when you show up at the hospital. And then I have co-insurance, but we've paid our share. And then now the anesthesiologists and the hospital system are chasing us, and my insurer is going to resubmit the claim and just slow. So it's, even if you know exactly what you're supposed to pay and you know how to speak to everyone, it's still a slow and inefficient process.
Yes, and sometimes purposefully so.
Yeah. That's right. On both sides.
They're holding onto your money as long as they can,
yes,
right?
The payer wants to delay it as long as possible. And the providers are trying to just yell at me and send me text messages so I'll get sick and tired and just pay it to make them go away, even though I don't owe it. So if you really don't understand it, it can be hard to navigate.
It'll be interesting to check this out when I learn a little bit more about it. It's
and then Mistral, which is a European-based AI, it's an open source AI platform that then is monetizing through services, kind of like Red Hat did. They just closed a new round, $600 million at a $6 billion valuation. So the value tripled in 6 months. which is incredible. I mean, maybe it's worth it. I don't know, but that kind of growth it seems crazy to me.
I hadn't heard about this company, so thank you for sharing it. My mind just kept racing to how many crazy valuations there are going to be, and there's going to be some incredible companies built out of this, but there's also going to be some people left holding the bag because they had a crazy valuation just because it's AI.
Yeah,
that's what right. I just couldn't help stop thinking about.
Yeah, that's right. And Mistral is an open source system.
Yeah.
So like, yes, it is convenient, and a big European company. Europe has lots of privacy differences, and so I think they are trying to structure themselves as the kind of the European platform as opposed to OpenAI, Google, and other things here. Anthropic, those are all U.S. companies. But I don't know. I think $6 billion seems like a lot.
Whew. Yeah,
we need a little bit of that in healthcare investing. Right. This was good. So a new. Well, Portfolia, I think it's their second fund. They just raised a second $65 million fund dedicated to women's health. And so that women's health has been under a lot of attention with the Biden administration, actually, calling it out as a focused area. And then also, of course, with all the Roe v. Wade stuff and even some of the in vitro has been challenging. Right. So I think it's great to see capital being deployed in this space. It's a small fund, but I think it'll be good. So, okay, so we're shifting over to payers now. CVS came out saying they're going to focus on really profitability, and that might mean they could lose 10% of their Medicare members by next year. We've been tracking this, like Medicare Advantage is getting harder and harder to be profitable now. You really have to be a strong operator. It seems like CVS is going to get more efficient, make sure they're profitable. And if it means they lose patient rolls, they lose members.
Right. You can't lose $1 on every patient and make it up in volume.
Right.
That's the old saying we have in hospitals. And I think they're understanding that they've got to get efficient, make it profitable, and then focus on growing the business once it's profitable. It's okay if you lose some beneficiaries when you're losing money. You've got to get it efficient. This will be an interesting story to track as things tighten up on risk RAF scores and the ability to make money on the top side. They're going to have to get more efficient on the cost side. Yeah,
and I didn't put it in here, but there's a new CEO at Humana too. Bruce Broussard is stepping down. I don't know the new guy, but that'll be interesting because Humana is the biggest pure play in
they're all in, right? Which seemed like a good bet 2 years ago. Now it's looking like, maybe we should have kept some of the commercial side of it, but absolutely they're going to have to figure out how to make money because they're all in.
Yeah. I think Humana has enough scale they can probably figure it out, but there's a lot to figure out. And then this was a pretty interesting summary article. We'll link to it, but Fierce Finance put through all of the payers in Q1 sort of side by side. And United, of course, had the cyber attack, which caused a big loss. But you can see that all the payers are less profitable this year than they were last year. And Cigna really has a good strategy to focus on the employer space only, the commercial only. But that transition, I think, maybe shifted where they don't have as good a quarter right now. I like Cigna in the long term, but they're not great. And Elevance is the dark horse. They've done a good job sort of kind of copying the playbook. I forget what their Optum-like thing is called, but they have a similar
strategy.
Yeah.
They're building it out, right?
Yeah.
And I've followed that a little bit, and it definitely seems like a good playbook. I wonder when the change stuff will wash through United. I mean, it always takes longer than we think. I think it's still significant. It's still ongoing.
They like allocated, I don't know, $1.5 billion or something. They already kind of did a reserve for it.
Watched it through the P&L. Yeah.
But they may or may not have reserved appropriately for that. Okay, then this was an interesting story. So United has invested over $1 billion in housing for their members, which is interesting. And what are your thoughts about that? Have you seen that before? And is that what a payer should be doing?
great story and positive, long-term focused. There have been providers that have focused on what we call the social determinants of health, right? Food and transportation and housing. And so the challenge with that is those oftentimes are incredibly long-term investments, and they pay off when people's long-term health is improved because they can afford a place, a roof over their head. So, I mean, that the point of this is, how can you worry about getting to see your doctor or getting your prescriptions filled when you don't know where you're going to sleep at night?
Right.
And this is a positive story. It's great to see that United's doing it. Obviously, in places where they have significant risk in Medicaid populations. So I was impressed to see the amount of money, and a little bit surprised that they were going this deep on housing. Seen some health systems do it, but not many. I think we will see more of it, both, payviders as well as payers.
Right.
But they have to be invested in the long-term success and health of their communities. And it's nice to see that United's making that investment. I'm oftentimes a critic of United, so this is really positive.
I was surprised at the scale, over $1 billion in 31 states. I mean, it's a pretty widespread thing that I had totally missed. And so that's why I wanted to bring it up.
Kudos to them. This is great.
Yeah. Okay, so shifting over to the hospitals, this is your core here. So the Wall Street Journal this week ran a story of hospitals refusing to do surgeries unless you pay up first. And you and I were talking beforehand, and you said that this is not news.
No.
Like this is
not new.
It's been the Wall Street Journal found a couple patient and put together a story, but health systems have been working hard to try to make sure they get the copay, get the patient's portion up front.
Couple thoughts here. Number one, with increasing deductibles, high deductible health plans,
right?
We're not talking insignificant.
Yeah, this is not $20.
This
is not $20, right? It can be $5,000, $10,000. Yeah, and then you have co-insurance. You might have a
exactly. Yeah. This could be losing money on the procedure or doing it for free if you don't collect up front, and that's just increasing every year. It's leveled off a little bit on these deductibles, but it used to be the deductibles were $1,000. Now it's $5,000, $6,000. Right. So we're talking real money here. The funny thing for me is that the expectation that we pay our copays when we go to see our doctor, like we've sort of gone that, like we do it. We just whip out our wallets when we show up to the doctor. They're not going to see us if we don't have our copay. Now, the reason this is a little bit controversial is because not all these surgery procedures are quote unquote elective. I think it's absolutely reasonable to get payment upfront for services, because we know in the hospital industry that once you provide the service, your ability to collect goes down by 50%.
Yeah.
And it costs you a ton of money versus getting that cash up front. So,
well, when I walk into an Apple store, they don't let me take a laptop out with just a promise. Well, just, send me a bill, I'll pay you later. No. That doesn't happen. And no one gets mad at that. And yet hospitals somehow have this quasi-public service aspect that is, I think, unfair. But as an operator, you had to navigate that, I'm sure.
Well, yeah, right. Unfortunately, right down the street, we will see homeless people outside of McDonald's who may not know where the next meal is coming from. They walk into McDonald's, they're not getting a free hamburger.
Right. Right.
I mean, I hate to
They're outside trying to figure out how they can get enough money to go buy it. And we all accept that McDonald's is a business. They need to pay their workers. They got to pay for the supplies. Hospitals are no different.
They're no different. Now, with that said, I think that the hospitals that are doing and surgery centers that are doing a good job of this, hopefully they're working very closely with the patients and coming up with a minimum so they're not deferring care. And that maybe there's a happy medium there, but setting the expectation that you should pay something up front and having the ability now to means test and to understand what people really can pay, and then working with them, getting to a point where you're not going to defer care. I can say, we had this policy in place in most of the systems that I worked in, and it was very rare that we ever deferred care.
Yeah.
I mean, it happened once a year.
You bring in a benefit support person, or they help them get signed up for Medicaid. Or,
there's charitable funding. There are things that you can do, but I think unfortunately a lot of times people sign up for their plan through work or through the exchange or wherever, and they do not realize.
They don't understand it.
They don't understand the amount of patient exposure, out-of-pocket exposure they really have. And for that first procedure of the year, it's all you.
Yeah. And then the people, no one understands coinsurance. That is like, so after the deductible.
Hey, I'm done.
Right.
I'm done. Everything else is free.
You still have to pay 20%, 30%, whatever it is. And instead of being mad at your employer or your plan, you just take it out on the health system.
That's right. There's a happy medium here, which is, listen, you should set the expectation that you pay in advance. You got to get money up front, but there's a way to work with patients to make sure that you're not deferring care and causing harm. There is a way to do that.
And so there's that story of the journal. Then this week as well, same week, a New York system in Rochester Regional is saying kind of the opposite. They're not going to sick collections folks on patients any longer, which is another strategy, right? Yeah. They're going to work with patients, and I think, reading between the lines, they don't want the negative PR. They do want the positive PR of coming out and saying that they're not going to do this anymore.
It sort of gets to the point, if you don't collect it up front, collecting on the back end is really hard, and very, very challenging PR, and it hardly ever results in positive outcomes. So why even do it?
Yeah,
I don't disagree.
It's better off just to say we're not doing it.
Write it off.
Because you're not going to collect very much anyway, and then focus on education, getting people signed up for Medicaid or whatever on the front end.
And this is the kind of thing that gets you on the front page of your local newspaper, and when you've got somebody who doesn't have the means. So again, I really think the answer here is working with patients and meeting them where they are. And yes, you will find a patient that does have the means and just doesn't pay. But most of the time, people want to pay their bills. And if you work with them on a payment plan and getting it to something what they can afford, I usually think there's a positive outcome, and then you don't get the negative PR. So good for them. I don't think it really works.
Yeah. So let's jump to CommonSpirit. So we had several for-profit systems over the last few months report positive. HCA, Tenet seem to be doing pretty well. They have higher volumes, they have higher acuity in their patient population, so they're getting more revenue, and they've managed their costs. Particularly their staffing costs are manageable, so they were all profitable and beating earnings. And then CommonSpirit came out yesterday with a $360 million loss, and so. What is the difference between CommonSpirit and the for-profits, or is it unfair to compare them? It seems like a big disconnect between what we saw from the for-profit providers and CommonSpirit.
Yeah, they had good volumes. Looks like a good payer mix. Mm-hmm. So good revenue. Really, operating costs are incredibly challenged. So. I think the for-profits benefited from some of the comps, right? Labor is better. It's still not good, and it's still a lot worse than sort of pre-pandemic norms. But if you compare year over year, it looks really good. Right. And we know in the public markets, sometimes what happens year over year is more important than the numbers.
The two I mentioned, HCA and Tenet, they're really good at investor relations and setting guidance where they have a good understanding they can operate to it.
And for those that I talk to in the for-profit health system industry, labor is better. It's not. It's still the number one problem, but it is better, and it's getting better, kind of quarter over quarter, month over month. The contract labor usage is down, but it's still more than double what it was sort of pre-pandemic levels, and it was challenging then. So back to your question on CommonSpirit, they don't have the markets. But they do have some good markets, and I think this is a call that they've got to, focus on efficiency. They've got to leverage their scale. They have significant scale.
They're one of the biggest systems in the country.
You've got Ascension,
140,
and they're huge. Now, so they have nationwide scale. I don't think they operate as a single entity quite the way an HCA or a for-profit does. It's sort of market by market, and each market does a lot of what they want. And it's positive on the clinical side, and there's autonomy, but why be big if you're not going to leverage your scale on both the revenue side, and we're going to talk about that on the payer side, but also on the operating expense side? You got to figure out ways to improve costs, supply chain, pharmacy costs, revenue cycle, all those things, staffing have to be managed tightly. And I don't know they do that across the entity.
Yeah. So they don't have the same payer mix or ability to negotiate, although we're going to, the next story, they're going to start working on that. But do you have visibility to how their operational efficiency is? Like if you could compare kind of apples to apples, if HCA was this exact same size, 142 hospitals, or do they have fewer levels of management? Do they run more efficiently? I would think so, but I do not have
inside baseball.
Yeah.
But it's a small industry, and CommonSpirit has a reputation for being big and challenging to navigate, a little bit bureaucratic, nowhere near as efficient as the for-profits. With that said, HCA has Nashville and Denver and Dallas.
Yeah, they have great markets. Right?
So that's the best strategy they've ever done is they're in great markets, but they're also really good operators. I think CommonSpirit doesn't have the luxury of exiting markets where payer mixes. They have their mission driven, which is great. So they have to be more efficient, use their scale and size to drive efficiencies, not create bureaucracy and layers.
Talk about that. They don't have the ability to exit markets in the framework of this news story, which you brought, which is great, which is CommonSpirit is taking a firm stance with payers, really, particularly with Anthem. They are in a negotiation fight with Anthem over rates and the network and network pricing and all. Pretty typical fight.
Yep. They walked away.
And so they maybe are willing to abandon markets. At least they have threatened that, and they walked away temporarily.
So my belief is that, yes, you have to have a reasonable payer mix and the reason why I want to talk about, the reason why profits are important is not for profit's sake, is you have to reinvest in these markets. I mean, you have to reinvest in technology and operating room and staff. And so that's why profit's important. They're not taking money out, but they have to be profitable so they can have the best facilities.
I mean, just sustainable.
Just to pay their bills.
Right.
But then hospitals, health systems are capital intensive. Yeah. And if you want to have the latest and greatest, I want to go to some place that's investing back in their system. Right. So that's why profits are important. And HCA does a good job of that. And the other for-profits, they do a good job of investing back in. So I also believe that you got to get paid fairly. You cannot reinvest and be profitable if you're not being paid fairly. So in order to get paid fairly, sometimes you got to go to the mat. You got to be willing to walk away.
If you never walk away, you probably are not getting the maximum pay.
Right. And my experience in working with lots of not-for-profit partners is that's very, very hard for them to even think about doing. Mm-hmm. Two things that maybe they haven't done a great job of is, one is leveraging their regional size and scale.
Yeah.
So example would be, are you taking all of your hospitals within a certain state or a certain market where you have a payer who cross states and making sure they're negotiating as one so that they have more relevance with the payer? That's number one. And number two,
and you can help me explain this, but there might be certain assets like a children's hospital or Life Flight or a burn center or something that you have to have in the network. And that can be used to leverage negotiated network pricing, but you have to be willing to fight for it and take it, like put it on the table as if you don't give us what we need to operate the whole system, then you can't have access to this asset.
That's correct. And you would be surprised at the sometimes lack of leveraging that scale and size that occurs. And I'll give you an example. I'm not going to, it's not CommonSpirit. It's not,
but we don't need a name.
We don't need to name a name,
in
but
general.
In significant presence with significant assets in one state, and it's every man for himself. They do not come together. And
they don't bring the facilities together, the health systems together.
Correct. Even today's day and age. So, you got to do that. You have to.
But the payer's doing that. I mean, the payer is negotiating. Right.
Of course they are. And they're leaving billions on the table by not doing it. So you have to have relevance with the payers. You have to use what you bring to the table, whether that's trauma or children's hospital or just your number of facilities in a certain area. And then you have to be able to walk away, or the payer needs to think you're going to walk away. And every once in a while, you have to have a shot across the bow like this. that, yes, if we're not going to get paid fairly, as painful it is for both of us, we're going to walk away.
Yeah. So talk about what walking away means, because I mean, we have some listeners that are health system leaders that will know this, but not everyone is. So CommonSpirit, if someone comes to their emergency department, they have to take care of them, even if they're an Anthem member. And so they walk away and they don't accept Anthem members, but for certain procedures, for any of the emergent things, they can't really abandon it. So they end up losing elective, which are kind of the higher margin, better areas.
Yeah. It's painful for the health system. It's also painful for the payer too, right? Think about it. If you live in a community and your local hospital is now at an out-of-network and you have to change, you have to change providers, you have to change doctors, because the doctor can no longer see you and you were going to have that surgery there, but you can't have it done there. And Blue Cross has to send you a letter notifying you that...
Yeah, everyone's mad and they're calling their HR department or they're calling Blue Cross. And
they call the hospital a lot too. What are you guys... it is a very challenging situation, but if you don't go, that's really the only lever that health systems have and providers have. And we'll talk about the surprise billing piece of it, but it used to be that, yes, you had to take care of the Anthem patient in the ER, but you were no longer getting a discount, right? We don't have a contract.
Right.
You can't just pay me what you think you...
Right. I'm going to bill you my
usual and customary
charge rate. Yeah.
I think that steak's worth $15. That's what I'm going to pay you. Now, the legislation has really made it hard for providers to be able to use that as a stick to say, hey, that's great. You're going to take away all our elective patients, but you're also not going to get that discount when you come in the ER that you negotiated. You're going to pay full price. It's challenging. So it's going to be painful for both parties and probably more painful for CommonSpirit. But the alternative is getting paid unfairly and losing money on every patient. So
if you, let's leave CommonSpirit aside. If you were on an executive team at a large nonprofit and you had 100 markets and 30 are not, just the payer mix and the population lack of growth and just there are markets that are not going to be profitable. And you try to leave. There might be some markets where you're the only significant health system there because the for-profits have left those markets. Right. And so what happens?
It doesn't often happen that you're not able to. I mean, if you're a sole community provider, typically you have more of an ear with the insurance companies because they need you, right? Where it really becomes challenging in markets where Blue Cross or a single payer is dominant, and there are markets where a single payer has
Alabama. They have
Alabama Blue,
that's probably
80% market share,
right? 87%,
whatever it is. Okay, so and there's plenty of hospitals in competition, and their line is, hey, we're gonna pay you our Blue fee schedule, and you're not gonna get more of that. When everybody knows they pay different rates to different folks. So it all comes down to your relevance with the payer. It's not pretty when you have to go at a network. And by the way, it should be an absolute last resort for those that used it as a strategy. And maybe we may talk about that. I think it's bad. It's awful. It's not fair to the patients, and that's not a strategy. The strategy should be
you should not be designed. We're never going to be in network because we want to be. Our network is our strategy.
Well, it doesn't work anymore. It's done. We've seen some
the no surprise stuff killed that.
Those days are gone, and that's probably a positive.
Good. Yeah,
and that's what it was intended for, is those bad actors who were using out of network as a strategy, not taking away leverage of somebody who's a good local hospital who's just trying to get paid fairly, or a good local physician group who knows that they're getting paid below the average amount, and they're just trying to get paid fairly. They don't. So the intent was good, like a lot of things the government does. The intent was good, take away these bad actors, but it has some unintended consequences.
Well, our payer provider system sort of relies on that negotiation and the kind of the free market being able to work. And I think what I'm seeing is that the payers are adding provider services, they're delivering care in higher margin or more like patient management, case management, patient care coordination sides. And they're not adding things that are not really high margin. And the health systems haven't been able to build as much strength on the payer side. Like they could also start moving into underwriting care, but they haven't been able to do that at scale.
And they haven't been competitive on sort of the bread and butter outpatient stuff, whether that's outpatient surgery, outpatient imaging, urgent care. And so you either got to build that and build it at a competitive price or get paid really well for the services where they need you, like trauma, like intensive care, high-end surgery, cancer care. You got to do one of the two or both in order to make a margin.
Yeah, and too many of the I don't know the facts for CommonSpirit, so I won't tarnish them, but too many systems are not building outpatient strong enough. They're sort of just leveraging the inpatient ORs they have, and those are not as efficient. They just don't run the same. So if I want a new knee, I'd rather go to an outpatient. Yeah.
I mean, as part of the health systems, they had outpatient imaging centers. We had ASC joint ventures with physicians, and I brought a lot of stuff from ASCs into the hospital worlds in my ASC partnerships. But never could I get the turnover times in any single OR as good as I could get the turnover times in the ambulatory surgery center.
Yeah, right.
Or the physician satisfaction.
It's a cultural thing. I mean, it's the same thing place where you started. Like if you start in a culture of an inpatient facility, the thing of running an outpatient facility is a different animal.
It's a different animal. So there are ways to do. I was surprised. It felt like there was quite a bit of momentum kind of leading up to COVID on health systems figuring out ways to do different kinds of creative partnerships. So they had the outpatient footprint, and a lot of that got stalled. And I still think there's work to be done there and opportunity there from an investment standpoint and partnership standpoint, because the footprints are not where they need to be. If you're truly going to be, a payvider, or you're going to be all things to a payer and take on risk, you have to have that umbrella of services, and maybe the way to do it is to partner. So I still think there's great opportunity, whether that's outpatient imaging, urgent care services. We've seen health systems do partnerships there, and still, believe it or not, in the ambulatory surgery.
Yeah. Well, we have too many inpatient rooms and not enough outpatient services nationwide, I think. So, okay. So let's get into the private equity. FTC, Federal Trade Commission, has been attacking private equity on a lot of fronts, but certainly in healthcare. And Wells Carson won in federal court. Federal judge dismissed the case against Wells Carson, not against all of their partners. So U.S. Anesthesia Partners is still there, but the case against them was dismissed. So this is related to the No Surprise Act and the out-of-network stuff. You have a lot more experience in this. What is your takeaway from this?
Yeah, I don't think USAP falls in the category of solid. I don't know that they were ones, they certainly used it as a lever when needed, but, they were in network, and that was not a strategy for them. But just like we talked about.
But they sort of aggregated negotiating power, definitely. Which is allowable business strategy, I think.
Yeah.
It should be allowable.
And we just talked about, Blue Cross of Alabama having 80% market share. They don't see the FTC going after that. So Wells Carson, good investors, glad to see them off the hook in this. Hope USAP gets off the hook. They're aggregating doctors. Doctors are choosing to join them because they believe in that there's something good. And it's not just revenue and leverage, that there's something good about being part of something bigger. And, good for them for providing that. Doctors aren't being forced to join USAP, and hospitals aren't.
I feel like anesthesia practices are commonly criticized because the patient doesn't typically know who's being used, or they don't have that option. They're picking their doctor, maybe they're picking their facility,
right?
And then they just get whoever they get.
That was exactly the impetus for the No Surprise.
Yeah, right.
And as we talked about, I get it, right? I get the patient concern of getting a bill and being like, I have no idea why I'm paying an out-of-network. I had no choice of that. That's not fair.
Right.
At the same time, we just talked about, you have a group of physicians who are trying to get paid fairly, and the insurance company just, stiff arms them what's their recourse? They just either do nothing and just take it. So it's a very challenging issue. I think the answer is the free market has to prevail. We can't have government stepping in and trying to fix it. And ultimately, I think the people who pay the bills have to vote with their feet and fix it, whether that's the employers or the patients, but it's really the employers. Yeah. They're the ones who really have to.
The commercial market is really where there is a group of employers that could push for change if they wanted to, but so far they haven't really woken up.
I would agree with that. I thought we were in a move, whether that was kind of a move to narrowing networks, right? They can vote with their feet. They can say, hey, hospital system B, we don't like your pricing. We're going to take you out of our network and we're just going to go to health system A. Yeah. They can do that, and they can also impact what their employees pay, incentivize healthy behaviors, penalize unhealthy behavior. Yeah. And they can also actively manage their employees, like make interventions. So there are things they can do, but it just maybe because health insurance costs kind of leveled out, I think that's going to change.
Yeah, I do.
This year is 8%, 10% premium increases. Yeah. That's not sustainable.
Well, and I think the employment space it got really tight finding employees, keeping employees right after COVID for health systems, but for every business. And I feel like in 2024, we've had a few layoffs, but mostly it's just softened where it's not that hard to find new employees. And I think that that's going to end up with the pendulum kind of swinging back to looking at benefit packages like on the table. Should we reduce our exposure? Should we do a narrow network? Should we look at a center of excellence or any of the above?
Interesting. We saw that in the fertility industry. It was a great thing for the growth of Ovation is that we saw employers adding fertility benefits.
To attract people. It's a huge way to attract a kind of a higher educated, higher income, higher talent employee base to offer fertility.
It is slowed. But it's slowed. For just the reason you talked about is I think that competitive dynamic is not what it was coming out of COVID. And so we saw that still positive. We're still seeing employers pick up fertility benefits. Yeah. It's the right thing to do.
But the growth rate has slowed. I think it was brilliant for you to, get out at the price and, because it's going to be the growth is going to slow down. You can keep operating and they'll do well with that. It's a great set of assets they acquired. It'll be fine, but the growth is not going to be the same post, this kind of downturn in the economy.
Yeah, I think you're right. I think you're right about that.
And so this was kind of a surprising story. Kaiser Permanente built up to $57 billion in private equity assets. So, they're a payvider, very well run, one of the best platforms. But is a nonprofit health system or health system / insurance company supposed to be investing so much in private equity? I don't know. And so they are selling off a lot of it. They came out and announced that. So they're going to sell a little over $3 billion. I work with people in the VC arm, which, it's the smaller of the two. And they even are moving towards like really understanding how is this going to be effective in our operating business? How are we going to deliver
$57 billion just private equity and the VCs on top of that? Or is that?
No, that's inclusive. That includes
that's a huge number.
It's a huge number.
I would have never guessed that.
And Ascension has and it's not quite that big, but Ascension has a big private equity thing too. Kaiser is much more in partnership with other funds, whereas Ascension is much more holding it directly. So it's just interesting to see these nonprofits have built up a significant balance sheet, obviously. And I think there's, depending on who wins the election, there's some, I guess, living in Nashville, there's always some discussion about should there be property taxes or should there be other things for nonprofits when you see this kind of scale.
Yeah, the Ascension model is interesting. They've got the relationship with Towerbrook. So sort of the rinse and repeat. Let's take a company that works inside of Ascension, revenue cycle, which is R1 is the revenue cycle. Let's build it. Let's bring in outside customers outside of Ascension, take it public. And they've done that for revenue cycle. They've done it for biomedical engineering. The company's called TriMedics. Little different approach. And they probably look at it and say, hey, we have significant control in those investments, and that may be a difference here. But they've done quite well with those investments. Whether it should be allowed or not allowed, that's a deep rabbit hole. I'm not sure we got the time.
I don't know, but building up a balance sheet to keep the nonprofit sustainable, clearly they should be able to do that. But there's a level where it seems like a lot.
Right.
We probably won't solve that right now. Okay, so we're going to shift now to, we talked about the first really cures in sickle cell last week in gene editing, where patients are being cured now. And there's a story in Forbes about sort of how this is beginning to extend to other diseases like Huntington's disease and I wanted to get your thoughts about it because obviously it is a huge impact to someone's life, to their life experience. If they have one of these rare genetic diseases, it can be really difficult. It's really debilitating, very expensive. If we can cure them, that sounds wonderful. It is wonderful. But some of these, the example they give it's $1 million per patient to cure them. Now they're curing someone of Huntington's disease, which is an expensive and terrible disease. I don't know exactly where it is, but it's in here. What our reimbursement system is not designed for that.
Yeah, I follow this, and I can't say I've truly understand the science, even though I've read a ton about it. It's truly amazing what is happening. And then you were hoping that we were, sometime in the next decade, certainly in my lifetime, that we'd see significant advancement. We have.
Yeah.
And I was excited to read this. And then I got to the million and had to do a double take. Like, is that really possible? We're talking like per patient. Either the cost has to come down drastically, or you just don't see how this gets widespread use. So,
well, let me just talk it through. If you have Huntington's disease, you're very expensive as a patient for either the federal government in Medicare or maybe for an employer. And that's going to be expensive for years until the patient dies. You might spend more than $1 million. You probably would spend more than $1 million over the life, but we don't have the infrastructure. Maybe the federal government would be okay in Medicaid, but for an employer, they're going to spend all that money in 1 year, and then that person, it's probably the parent of a person with Huntington's disease. They're going to go on to somewhere else, and we just don't have it's not designed for that.
Yeah, the question is, in a country, Canada, socialized medicine, what would they do? Where does the price point come in where it makes sense to invest in this? Huntington's is a terrible disease and death sentence, and you would think there's not enough. You would do anything you could and pay any price, but if you're not able to do that and someone else is footing the bill, what's the equation where there's a return on investment? I don't know.
So
it's sort of the same thing with the GLP-1s, right? I mean, it's sort of the same question: is where does that ROI come in for this expensive drug?
Yeah. The difference I think in genetic treatments versus GLP-1 is you pretty much are on Wegovy or any of the GLP does for life. Right. You might taper.
Yeah.
But you're going to be paying that. And if you change jobs, your new employer will be paying that. This is a one-time, very expensive one-time thing.
Yeah, good point.
That's where our system is we're just not designed for that.
Yeah, it's a fix. It's a cure. You don't have it any longer. You live a happy, healthy life. I agree with you. It'll be interesting to follow this.
Okay, so now we're going to move to the AI fund. Every week, there's just massive changes in AI. And I always think on Sunday, Monday, well, maybe it'll be a slow week in AI, and it's not. And so the Wall Street Journal had this story about a flood of fake scientific journals. Wiley, which is a big publisher of journals, just closed 19 titles, 19 journals. They told the journal that 11,000 papers were compromised. And so how do you think about that as an operator? Like, a peer-reviewed scientific journal used to be the gold standard.
It's a source of truth, right?
Yeah, right.
I mean, yeah, and certainly, we did a ton of work and research in the fertility space, and yeah, I mean, you relied on that. It's scary. It's disappointing and scary that, but this is kind of what we're dealing with, is all the great use cases we're going to see for AI.
Yeah,
that where patients are getting better care more efficiently, and we're all there's going to be these stories where it's being used for bad. And secondly, I didn't know the industry was that big, the amount, but yeah, 11,000 papers. That's scary.
And then the journal pointed me to this site, which tracks the retractions. And so they have a listing of published papers that they have found to have used ChatGPT for part or all of it. And just like for people that are watching or listening, I'm going to scroll through. There's over 90. I mean, it's not like one or two. There's a ton of them, and they're all in 2023. They're all like right now being put out, and it makes me question the whole thing. Like, yes, they've found these ones, but there's more coming out all the time. I'm sure.
Right. Yeah, it's prolific. I mean,
so like we worry, like I have a high schooler, you have high schoolers. The high schools are worried about how can we keep kids from cheating on some English paper. And yet at our most important research institutions, they're doing the same thing.
Yeah, it's a little bit
crazy.
Scary.
Yeah. Okay, so OpenAI and Google both had announcements this week, but the more interesting thing to me, and we'll cover that in a minute, but interesting is that Ilya Sutskever, I'm not sure I said that right, but the chief scientist at OpenAI, who was at the core of Sam Altman getting fired and then rehired in November, almost exactly 6 months ago, he has left OpenAI. And so I think this is all the same story. There was some falling out. What's that?
It's going to be a movie one day.
Yeah, it's going to be a movie one day. After OpenAI has done whatever it's going to do, they'll come back, kind of like Facebook, the movie, like 10 years later, they'll do. Yeah, there's a whole backstory. I don't know what it is, but Ilya has moved on. He really was the reason that a lot of the talent went to OpenAI. And I don't know what the backstory is, but it seems like you wouldn't leave the best platform unless there was some major difference.
We don't know where he's going.
No, he hasn't said where he's going. Okay, so then that's sort of the negative news out of OpenAI, but they had a release on, I guess it was Tuesday, and then Google had their big show on Wednesday. They kind of ran in front of the Google thing. And they released a new model called GPT-4o. O stands for Omni, because it works across audio, vision, and text all simultaneously. So they're using the phone's camera when you give it permission. So it's not always on, and it can use the camera to look around the room and understand where it is. And then in the demo, he has two phones, both with OpenAI's GPT-4o on it, and he asks them to like sing a duet right now. And whether it's great singing or poor singing is immaterial, but it sounds like two humans trying to just like make up a song and sing. And so I'm going to play it just because it's hard for me to say it sounds like two regular humans talking through this without just playing it. It's not that long, so.
I just sing a song about what just transpired.
Oh, in a room with a stylish view, a person stood in sleek black and light hue. Engage with us so
And can you alternate lines?
Mm-hmm. Person with style and speed, person with style and sleek, with a playful moment right in the mist, in the room. In a room where modern lights peak.
Only one line at a time and then stop.
In a room where modern lights peak.
A surprise guest with a playful streak.
That was not really singing. Do the singing voice again, please.
In a room where modern lights peak.
So I found it really interesting that I can imagine you and I sitting in a room with one other person, and I would be that second phone, like kind of half-ass singing, not really wanting to do it. It's very human-like. So I understand that it is not human cognition, that it is faking what it sounds like to sing as a human, but it's very realistic. It sounds very lifelike.
I went to the healthcare kind of, what does this mean? And sort of the ambient listening, watching what's going on in the healthcare setting, digesting that, documenting that, making, quality, taking everything in, and then sort of the remote patient monitoring and remote patient engagement, particularly the visual side of it, was pretty remarkable. So, and what that tells me is it's just not that far away. We're there.
Oh yeah, it is. It's ready from a artificial intelligence processing speed. I mean, the latency is undetectable to me. Like it is. Maybe there's microseconds, but it's fast enough that it's responding like a phone call would be with another human to me.
Yeah.
So anyway, that was OpenAI. They jumped in front of the booked for a long time Google event. And I pulled this from the Wall Street Journal because Marcus was saying last week that he felt like it was like the movie Her, like the technology had grown to the point where it's you could have a relationship with the AI, and the Wall Street Journal had the exact same quote. So this reporter clearly listens to the show.
Right. We all know Marcus is prescient, right?
Yeah.
I mean, that's no new news.
Yeah. So we can let's go to last week's where he talked about this.
That is the movie Her.
Yeah.
Just so we're clear. So if you want to get an immersive, emotional experience of what that is like, just pop on Her, because they did a fantastic job of predicting where we were going to be. I tell you what, they nailed it.
And we're pretty much there.
The device looks like the Rabbit R1, and it's a voice-based GPT.
Yeah. Yeah.
Totally.
Right.
It's crazy how well they nailed it in that movie.
Yeah. So obviously, you can see last week he was talking about this, and the Wall Street Journal were happy to help feed you information. So it's as you said, it's fully functional. It can be text, visual, audio, and just kind of chatting and building a relationship with people now.
Yeah, I mean, clearly, given what the impact we're dealing with in healthcare, it's going to take longer for this to be adopted. Mm-hmm. But it's exciting to know that we're not talking years, really. Yeah. I mean, it's in our future, and there'll be some really exciting pilots of this in the healthcare setting. And what's most exciting to me, I mean, there's applications in the hospital, in the clinic, and what happens at home when nobody else is watching, to think about what the impact could be of somebody watching. Now, that's also scary, but it could really have an impact.
Yeah, I mean, I think about home health. Right? Like the patient could benefit from someone being there a lot more than they are. Right. And then the home health worker, there's a lot of data entry and a lot of keying in what the vitals were and recording what services you did, that you could be empowered and not have to do all of that work.
Yeah, and if it was being supervised and piloted by somebody who's experienced and licensed, who's operating at the highest part of their license, but is doing all that stuff kind of behind the scenes and patients getting care, it could be incredible.
Yeah. Okay, and so then Google, the next day, it's a 12-minute video, so I'm not going to play it, but we'll put it in the show notes. But they came out and dropped all kinds of new releases. So they have a new model that is more powerful. It incorporates vision, like using the camera, just like OpenAI had done the day before. But also they are now embedding their AI tool, which is called Gemini, into all their main search page. So
you don't have a choice. You will use, if you're going into Google and you're searching, you're basically going to get Gemini.
Yeah. So next Wednesday, I think, across the entire US, Google decides if a search is complex and has several parts to it, it will give you the answer using AI. And the links are now down below, but it just says, Paul wants to know where to go eat in Phoenix, and it'll recommend a couple of restaurants. It does not give you links to a whole bunch of things. And so that is, I mean, it's the biggest search engine by far, right? It's almost not the only search engine, but they have 90% market share. I don't know what that does to the internet. Right? So if you start just giving the answers, it's wonderful for the user. But the people that are writing reviews about restaurants in Phoenix and building that content that the AI is using,
right,
they're not going to get traffic. They're not going to get ads. So they're not going to get the clicks. And so I don't know how the model works. Like Google makes money from the AdWords. So they are cannibalizing their own business, which I give them credit for. I thought about because someone's going to do it, but I don't know what not even long term, like a 6-month, 12-month effect is.
Right. In order to keep up with OpenAI, right, and people are migrating, it's almost like they have to do it.
Yes.
Yeah.
Yeah, they have to do it. And it's going to change the way that content is created because there's not going to be the same kind of monetization plan.
Well, it's funny. I hadn't thought about it in that context. Now it makes sense because I wasn't sure what to take away from this. But there are times when you'll go to ChatGPT and times where you use Google, and Google doesn't want you going away from Google.
Yeah.
Right. And I did it the other day where I was like, this is a perfect conversation with ChatGPT.
Yeah. I can ask.
Right.
It's like a little more hard to put in 5 words in a search bar.
Yeah.
And I just want the answer. I don't want to go do a bunch of reading up on things. I need a black and white answer.
That's it. Okay.
And then they both are negotiating with Apple Apple's going to pick one of them to be the AI tool, I think, beneath Siri. So Siri is on every Apple phone, but it's not very good quality. No. It's almost useless. Yeah. And I think Apple at their developer day, which is like in a month, is going to pick one of these 2 platforms. My prediction is that they're going to go with OpenAI GPT is going to be their partner, but not with Microsoft. I think Sam Altman's going to do a direct deal outside of Microsoft, but I have no inside information. This is my guess.
Interesting.
But Apple has been public about their negotiating with both OpenAI and Google right now. Yeah. So then the other things they rolled out were gems. So that's kind of interesting. It's not in this story, but they rolled out. This is the search story. Gems are their brand. One of the things that bothers me with Google is they have too many brands. Like yesterday, they announced 4 new brands, and I don't want to remember all these brands. But Gems is their internal brand for an agent, which is like a instance of an AI that would be trained and really good at one particular thing. So in the next couple of weeks, if you have their Google Advanced, it's like $20 a month, which I haven't been. They're going to release this ability to make agents where, like, I want to do a healthcare coach that just sits there and I can ask it healthcare questions. It knows my interests. It knows my situation. But you can do a strength training coach, or you want to learn Spanish. So they're like little pieces of Gemini that are tailored just to one particular use case. And then when you go to it, it's just talking about that.
Have you calculated all of your subscriptions yet, or you don't even want to know the answer to that?
Yeah, I keep up with it. It's about $350 a month.
A month, okay.
Yeah.
But eventually you're going to trim that back once you figure out
I'm
which
testing
ones.
a whole bunch of them.
Okay.
Many of them are 10. They're all 10, 20.
Right. Nothing's going to break the bank, but
right.
Yeah, you don't need all of them. At some point, you're going to figure out what are the best. But that's going to change. I mean,
it changes. You know, I add new ones all the time. I added an $8 one 2 weeks ago that seems more powerful than a $200 one that I added 6 months ago, just because it has, changing so fast. So that's all the stories we have. So Paul, thanks for doing this. Any other comments or things that we didn't cover that
I enjoyed the show. Thank you for having me. It's been fun to hang out. It was always fun to talk and riff on healthcare stuff. And it's even more fun when Marcus is here. So
we need to have you back as a guest and go deep into something around health systems or maybe your next project or whatever you want to talk about.
Love to do it anytime.
So,
thank you.
Okay. Thanks, Paul. Appreciate it.